Hello everyone, I'm Dr. Disha from SRCC Children's Hospital managed by Narayana Healthcare, and I have Dr. Supratim Sen, Senior Consultant Pediatric Cardiology with us to discuss the topic Tetralogy of Fallot. So can you tell us what is Tetralogy of Fallot?
Thanks, Disha. So let me just explain based on this diagram. So Tetralogy of Fallot is the commonest cyanotic congenital heart disease, what is also known as a blue baby. So there are two main defects in this disease. First, you have a hole in the heart. You can see this hole between the two pumping chambers, which is allowing the deoxygenated or blue blood to mix with the red blood. And in addition, there is a block in the vessel which is taking this blue blood to the lungs. This is known as the pulmonary artery. So when you have these two together, along with some other additions, this is known as Tetralogy of Fallot.
So can you tell us if it can be diagnosed during pregnancy?
Yes, so Tetralogy of Fallot can be diagnosed by fetal echo as early as 16 to 18 weeks of gestation during pregnancy. And when we are making this diagnosis, we also look at some additional findings. For example, we see how good is the flow from the pumping chamber into the pulmonary artery, what we call antegrade blood flow, and we look at the sizes of the pulmonary arteries. So there is an extreme form of Tetralogy of Fallot which is known as pulmonary atresia, and it is important for us to differentiate these two when we are doing the fetal echo.
So what advice would you give to patients who are diagnosed with TOF during pregnancy?
So whenever we make this diagnosis, first of all, we reassure the parents that this is a treatable condition. We have good surgical outcomes of this. And now that it has been diagnosed at the correct time, the baby after birth can be treated at the optimal time and they'll have great long-term results. Secondly, based on our fetal echo findings, we also advise the parents whether the child should be delivered at a cardiac center, which means that we can see them immediately after birth and then we can plan the further treatment accordingly.
So if not diagnosed antenatally, then what symptoms would a child of TOF present at birth?
So the commonest symptom is what we say is desaturation, which means that the oxygen saturation of these patients will be low. Now what is low? A normal oxygen saturation is 95 and above, and generally a Tetralogy of Fallot will have saturations which are less than 85%. If these patients are saturating, say, somewhere between high 70s to even low 80s, we don't need to do anything immediately. We just keep them on close follow-up. But a child who is saturating in the low 70s or less than 70%, then they definitely require some treatment. In addition to the saturation, the other thing these patients have is what is known as a cyanotic spell. And during a cyanotic spell, when these babies are crying, they become extremely blue. And that happens because the flow into the lungs gets really shut off. And this is kind of like an emergency. It needs treatment. And then we need to plan for future surgery.
If the baby with TOF has low oxygen levels, how do we manage that?
So first of all, if the child has a cyanotic spell, that is an emergency, and we advise the parents to keep the baby in a knee chest position. If the baby is irritable, then they should pick up the baby and try to console so that the baby kind of doesn't cry as much. And then they should come to the nearby hospital so that we can give some IV fluids, we can give some medications to try to settle the baby. A child who is stable but has low saturations, we start them on a medicine known as propranolol, and this is continued till the time of surgery. Now, as I mentioned, if you have a baby on medication who has a saturation above, say, high 70s or 80%, then we would wait till about 5 to 6 months of age to do a complete repair. But often these patients will be quite blue. Despite the medication, they might have oxygen levels which are, say, 70% or less. And these patients are then, they require a palliative procedure. So we have various options for the palliative procedure. The oldest palliative procedure is the BT shunt, also known as an aortopulmonary shunt. And what the surgeons do here is they connect the body artery, the aorta, to the lung artery, the pulmonary artery. This in fact is one of the oldest cardiac surgeries which was done. It was done way back in the 1950s. The newer version of this, what we do in the cardiac cath lab, is known as a PDA stent. So nowadays we don't need to do a open surgery for these patients. We can go through this small vessel which the babies are born with, and then we put in a stent into that, enlarge it, so that there is a good communication between the aorta and the pulmonary artery. And with this, then there is good oxygen level till the time of the next surgery. There is a third option which we have started doing over the last 5 to 10 years, which is known as an RVOT stent. So if you see here, we can pass a wire through this stenosed pulmonary artery, and then we can put a stent in there. And once we enlarge this stent, then there is going to be better flow across this pulmonary artery, and that again helps to maintain the oxygen levels in these patients till their complete surgery.
Sir, at what age do we plan a complete surgical repair?
So studies have shown that the best results with complete surgical repair are between 3 to 9 months of age, and in India we will be very comfortable operating these patients even at 5 to 6 months of age. There are, however, some patients who will present to us late. So suppose someone comes at 1 year or 2 years of age, we would operate them as soon as they are diagnosed. And in fact, at our center, we have also done early surgical correction of TOF as early as 3 to 4 weeks of age. And these are very small babies, but with the correct expertise, they also have good results.
So, is it a single surgery, or do this patient require additional surgeries later?
So again, let me come back to the initial picture of TOF. What the surgeons do during the surgery is they will close this defect, they do a VSD closure, and they will open up this block which is known as a pulmonary valvotomy. Now if this vessel is very small, then the surgeons are not able to preserve this valve. So they have to cut across and enlarge this, what is known as a transannular patch. And if that is done where the surgeons cannot preserve the valve in these patients, then they have a leak on that valve, and that grows as the child gets older, and a leaking valve will probably need a pulmonary valve replacement sometime in the second decade of life. If the surgeons are able to preserve this valve at the time of the first surgery, then it's a single surgery for the child.
Sir, are any minimally invasive options available for this pulmonary valve replacement?
Yes, so over the last decade, we now have percutaneous pulmonary valve implantation, which is a viable and a good alternative to a surgical valve implantation, and this is slowly being adopted at many centers in India also. It is still relatively more expensive than the surgical option, but over the next decade, I think it will become much more mainstream and much more affordable for the patients.
So what is the long-term outcome for these patients?
So Tetralogy of Fallot generally has a very good long-term outcome. If the patient is diagnosed and treated at the correct time, they go on to lead normal lives. Female patients can have a normal pregnancy, and they have normal exercise tolerance. They can do their daily activities. They can have an active lifestyle. So whenever we counsel the parents of a child with TOF, we give them a very good long-term prognosis.